Thank you for the opportunity to present our group's research at the 2020 SAGES annual meeting. My name is Brian Lowe, and today I'll be presenting the project, Do Specific Operative Approaches and Insurance Status Impact Timely Access to Colorectal Cancer Care? I have no disclosures to report. In the past decade, there's been an increased use of minimally invasive surgery, namely laparoscopic surgery and robotic surgery, in the treatment of colorectal cancer. Between 2008 and 2012, there was a nearly threefold increase in the use of laparoscopic surgery and a 40-fold increase in the use of robotic surgery for the treatment of colon cancer. This has led to much research on how certain factors may act as barriers in access to care. Studies have demonstrated that having private insurance or a higher household income were associated with an increased likelihood of undergoing laparoscopic surgery. That being said, very few studies to date have looked at specific factors that are associated with delays in care, and even less is known about robotic surgery, given its relative novelty and only recent acceptance into clinical practice. The goal of our study was therefore twofold. First, we wanted to compare wait times from colorectal cancer diagnosis to surgery and surgery to initiation of adjuvant chemotherapy, comparing open, laparoscopic, and robotic surgical approaches. We then wanted to investigate the impact of insurance status on wait times. We performed an IRB-approved retrospective study evaluating adult colorectal cancer patients in the National Cancer Database from 2010 to 2016. Our primary outcomes were wait times in days from cancer diagnosis to surgery and wait times in days from surgery to initiation of adjuvant chemotherapy. There were just over 704,000 colorectal cancer patients in the database during the specified time period. We only wanted to look at patients who underwent a radical resection, and we also excluded patients who received neoadjuvant chemotherapy, radiation therapy, or had metastatic disease, as these would have likely led to anticipated delays from diagnosis to surgery. We also excluded patients with data of 0 days from diagnosis to surgery, as these likely represented emergent cases. Therefore, our final study population of just under 325,000 patients went from cancer diagnosis to surgery to initiation of adjuvant chemotherapy in a sequential manner. Of these patients, 46.7% underwent open surgery, 47.5% underwent laparoscopic surgery, and 5.9% underwent robotic surgery. We then compared wait times between these three groups of interest. Appropriate statistical analyses were performed, and multivariable Poisson regression analyses were also used. Among our entire patient population, when stratifying by operative approach, we see that robotic surgery patients, when compared to laparoscopic and open patients, were younger, more likely to be male, have a higher household income, have private insurance, and travel a farther distance to the facility in which they were being treated. With respect to clinical and oncologic characteristics, patients undergoing robotic surgery, when compared to laparoscopic and open, were more likely to have cancer in the rectum, have fewer comorbidities, as evidenced by a lower Charlson-Deo score, have a lower TNM pathological stage, and also have smaller tumors. We looked at the proportion of colorectal surgeries performed robotically over time and found that there was an exponential increase from 2010 to 2016, from just under 1.7% in 2010 to 11.8% in 2016. We then looked at wait times from cancer diagnosis to surgery, as evidenced by the blue arrows, and surgery to initiation of adjuvant chemotherapy, as evidenced by the gray arrows. We found that patients undergoing robotic surgery experienced the longest wait times from cancer diagnosis to surgery at 30 days, compared to 22 days for laparoscopic and 17 days for open. However, these same patients tended to initiate adjuvant chemotherapy sooner, 48 days after completion of surgery, compared to 50 days for laparoscopic and 55 days for open. This produced total treatment times of 72 days for open and laparoscopic surgery patients and 78 days for robotic surgery patients. Next, we wanted to see the impact of insurance status on wait times. First, we looked at private insurance and compared that to Medicare, Medicaid, and uninsured, and found that a higher proportion of robotic surgeries were performed for those with private insurance compared to other insurance statuses. When looking at wait times from cancer diagnosis to surgery and surgery to adjuvant chemotherapy, we do see that insurance status impacted these wait times. Patients with private insurance and Medicare had the shorter wait times from cancer diagnosis to surgery, while those with private insurance had the shortest wait times from surgery to adjuvant chemotherapy. These findings held true after multivariable Poisson regression analysis, where we found that robotic surgery patients waited nearly 1.5 times longer for surgery compared to open surgery patients, but had the shortest wait times from surgery to adjuvant chemotherapy. Private insurance and Medicare were both associated with shorter wait times from cancer diagnosis to surgery, but private insurance was associated with the shortest wait times from surgery to adjuvant chemotherapy. Several limitations of the study must be addressed, including the retrospective nature of the study, as well as a lack of information on elective versus emergent surgeries. It is important to note, as I mentioned, that we use 0 days from diagnosis to surgery as a proxy for emergent cases. And thus, if bias exists with respect to this, it is likely to be minor. We also lack information on complication rates or surgeon volume, which would be an appropriate next step in the context of this study. In conclusion, colorectal cancer patients undergoing robotic surgery experience the longest wait times from diagnosis to surgery and the shortest wait times from surgery to initiation of adjuvant chemotherapy. Our study also demonstrates that certain socioeconomic factors, such as insurance status, impact the judicious and timely distribution of resources. This is important to recognize because as we continue to develop new technologies in the treatment of colorectal cancer, it's important that they are distributed to all patients in a timely and equitable manner. Thank you. These are my references, and I'm happy to take any questions. We appreciate the opportunity to present our research today.